Now, uh, we have discussed the Starling mechanism, and now we will discuss the cardiac vascular function curves. I discussed that whenever there is increased right atrial pressure, so what will be the effects on the cardiac output and venous return? First, we discuss the venous return. When the right atrial pressure is increased, this is the increasing trend like this on the x-axis. From this to this is increasing. When we increase the right atrial pressure, the venous return will be decreasing. This is vascular function curve. Okay, this is vascular function curve. Mean in our vessels, when there is right atrial pressure is increased, okay, what will happen? Venous return will decrease. Okay, what is if it is a threshold of right atrial pressure? Yeah, it's simple words. The pressure in the right atrium, which is at this level, that that obstructs venous flow, that obstructs venous flow, and at which venous return is zero. That is called mean systemic filling pressure. Mean systemic filling pressure. Okay, I will show it with a blue color. Mean systemic filling pressure. What is mean systemic filling pressure? It is the pressure in the right atrium that it causes the stasis of theoretically stasis of flow in our body. Okay, so that is called mean systemic filling pressure. So in this pressure, if like right atrial pressure, you can see this curve. This is zero. Venous return is zero. So this is the concept. Next, we will discuss the what is cardiac function curve. In the red, I will describe the cardiac function curve. So whenever the right atrial pressure is increased, like on the x-axis, well, we will study this cardiac output. What will be effect of cardiac output? Cardiac output will be increased when we increase the right atrial pressure. This is called cardiac function curve. So this is a normal cardiac function curve. Is that clear? Now, we will study the different changes. Okay, what are the factors that can increase and the decrease? Okay, the uh, effects on the cardiac function curve. Okay, so first of all, we will study what are the effects of ionotropy. If we give the any drugs that increases our synthetic activity. Okay, first of all, we will study this ionotropy. We will study number one. When we give the catecholamines, digoxin, and exercise, catecholamines increases beta 1 activity. Okay, it increases the beta 1 activity. Digoxin, we discussed in a yesterday lecture that digoxin causes increased contractility. Increase contractility. And exercise also activates the sympathetic system. So what will be happen in this diagram? You can see it is going to the left as compared to this normal curve. Why? Because when it goes to the left side, it will cause more cardiac output, more cardiac output. At a specific right atrial pressure, let's suppose it is, I am drawing this curve. Let's suppose here the right, theoretically right atrial pressure is 5. In the normal, there is cardiac output, let's suppose is the normal, like I am theoretically telling this, it is 100. But when we give the ionotropic drugs at this level, the cardiac output will be 150. Okay, so this is theoretical. Right atrial pressure is increased, so what will happen? Cardiac output increases. So curve will go to the left side. Okay, that is the important question. Next, what will be happening when we will decrease ionotropy? I will mark the decrease ionotropy with this color. This is decrease ionotropy. What are the factors that decrease ionotropy? These are heart failure, because there are a problem in contractility, in narcotic overdose, there are contract problem, and there are synthetic inhibition. So what will happen? It will be going toward the right side. You can say this picture. It is normal and going to the right side, it will decreases ionotropy because it's decreasing the cardiac output. Okay, this was the normal cardiac output. Now it is this cardiac output that is less than this. Okay, so this is due to heart failure with reduced ejection fraction, narcotic overdose, and synthetic inhibition. Next curve is venous return curve. What will be the changes in the venous return curve? Okay, so venous return curve in the picture, you can see this is a venous return. First of all, we will study the number 3 points, this point. fluid infusion and sympathetic activity. What will be the effects of fluid infusion? Increasing preload. Actually, when we increase the fluid, it means we are increasing the preload. Remember this. And increase sympathetic activity. What will happen? When we give the more fluid, more will be the venous return, more will be the right atrial, more will be the right atrial side of the pumping of the blood. So क्या होगा कि हम जब circulating volume increase करेंगे, the more circulating volume, there will be more change in the cardiac output, more change in the venous system. So हमारे पास ये जो डायग्राम्स होगी, बेसिक डायग्राम जो venous कर्व की थी वो ये थी, ठीक है. Now I will point out with a change. क्या change आएगी? When we increase the fluids, it will go upward like this. ये हमारे पास increase volume and venous return. और इसका उलट क्या होगा जब हम वॉल्यूम डिक्रीज करेंगे बॉडी में? दिस इज वेरी इंपॉर्टेंट क्वेश्चन फ्रॉम द एग्जाम पॉइंट ऑफ व्यू. वेरी इंपॉर्टेंट क्वेश्चन फ्रॉम एग्जाम पॉइंट ऑफ व्यू. लाइक द शॉक, हाइपोवोलेमिक शॉक, हाइपोवोलेमिक शॉक. इसमें क्या होता है? फ्लूइड कम होता है. फ्लूइड कम होता है तो ये कर्व क्या आएगी? नीचे आएगी. कैन सी लाइक दिस. नेक्स्ट इज टोटल पेरिफेरल रेजिस्टेंस. उस पे ऊपर क्या इफेक्ट्स आते हैं? अब हम डिस्कस किया था कि टोटल पेरिफेरल रेजिस्टेंस इज डिटरमिन्ड बाय आर्टेरियोल्स. Okay, so total peripheral resistance determined by arterioles. When we give the any drug that increases the resistance of arteriole, these drugs are vasopressors. These drugs are vasopressors. Okay, vasopressor drugs. So when we give the vasopressor drugs, what will happen? Total peripheral resistance will be increased. When total peripheral resistance will be increased, we discussed yesterday lecture in afterload will be increased. Okay, it increases the afterload. When afterload will be increased, there will be more problem for left ventricle to eject the blood. Then what will be happen? Stroke volume will be decreased. When stroke volume will be decreased, so curve will go to the below. So this is the normal curve. This is the normal curve. If I can point out in the 5, it is going downward like this. So it is going toward the below, which is decrease output. Okay, it was the normal output was here. Now this is the new curve after vasopressors. Mean it is decreasing the cardiac output. Is that clear? Next, it is the next 6 point. What are the causes that increases the cardiac output by decreasing total peripheral resistance? Okay, these are the exercise and AV shunts. Exercise and AV shunts. AV shunts mean arteriovenous shunts. Okay, arteriovenous shunts. इनका क्या है? They will cause decrease total peripheral resistance and there will be more cardiac output. Like this is normal and you can see this is a more cardiac output. Is that clear? So in summary, we discussed what is the effects of right atrial pressure with a venous return, like vascular function curve, and what will be the effects of right atrial pressure with a cardiac function curve. And we discussed different like ionotropic effects, venous return effects, and the total peripheral resistance effects. Okay, so this was the cardiac and vascular function curves. Okay, so going to the next. So what are the different changes that causes the change in cardiac and vascular function curve? Okay, so we will study vascular function and cardiac function. First of all, we discussed that acute arteriovenous fistula. What will be the change when there is acute arteriovenous fistula? You can see in this diagram the dotted line that shows there is change after there is occurrence of acute arteriovenous fistula. This dotted line and this dotted line, this shows this change which is seen in acute arteriovenous fistula. Okay, the dotted lines are in the different diseases. Okay, the full line that are normal, but the dotted line are in the different conditions. Let's next, what is chronic anemia? What will happen in chronic anemia? The normal curves are the blacks. Okay, these are the normal curve, this and this. But what will happen? The change in chronic anemic patients, there will be increased cardiac output. We discuss. Okay, this curve, you can see there will be more cardiac output and slight increased preload in chronic anemia due to decreased viscosity. So there will be a slight increase venous return curve. This is seen in chronic anemia. So chronic anemia, what will happen? Increase mild preload and increase cardiac output. Why? Because of decreased total peripheral resistance. Okay. So the chronic AV fistula, what will happen in chronic AV fistula? In chronic AV fistula, there will be the dotted line you can see here is that there will be increased cardiac output and more increased venous return. Acute arteriovenous fistula is having a slightly increased venous return, but in chronic AV fistula, there is a more increase in cardiac output, more increase in venous return. Okay, that is very important point. Next, we discuss what happened in acute hemorrhagic conditions, in acute hypovolemic shock, hemorrhage condition. What will, because the preload will be less in these conditions. Okay, preload will be less in these conditions. What will happen? The curve will go down like this. The dotted line is the curve which is different to this normal curve. So in acute hemorrhage hypovolemic shock, there will be decreased venous return, so the curve will go down. What will be the in anaphylaxis? In anaphylaxis, we already know that due to bacterial toxins, there is decreased total peripheral resistance. So when there is decreased total peripheral resistance, always remember afterload will be less. Decrease afterload. When there is decrease afterload, it will be causing more cardiac output, more stroke volume. So curve will be like this. And there will be more vasodilation because of in anaphylaxis, there is vasodilation of the vessels. And you know that in vasodilation, all the veins pulls up the blood. And when they pulls up the blood, what will happen then? Decrease in the venous return. Okay. So we discuss the cardiac and vascular function curves, and we discussed all these graphic representation in different diseases. Is that clear? So next, we will continue our next topic. What is the pressure, volume, loops, and cardiac cycle? Okay, pressure, volume, loops, and cardiac cycle. What will be the changes? Is that clear? So first of all, we will discuss what are the phases. Okay, I think there is a one page missing here. It's not showing here. I have put it. Let me check. I think the one page is missing here. I have put a very important cardiac and vascular function curves value. I think this page is missing. Okay, I will add it after the break. Okay. Next is the pressure, volume, loops, and cardiac cycle. Next, our topic is pressure, volume, loops, and the cardiac cycle. First of all, we will discuss what are the different phases in the cardiac cycles, what are the changes when valve opens, and what are the changes when the valve is closed. Okay. So first of all, we will discuss what are different phases in a cardiac cycles. Okay. In this diagram, this is a pressure, volume, loops of the cardiac cycle. This is very important. Understand this. We will take left ventricular volume that is on the x-axis, and we will take left ventricular pressure on the y-axis. Okay, and then we will make this diagram like this, and at this level there will be end systolic volume, and at this level there will be end diastolic volume. Okay, so this is the volume. Already I have told you end diastolic volume is greater and end systolic volume is less. So end systolic volume is this and end diastolic volume is this. Okay, now we will study one by one. Okay, first of all, we will study what is isovolumetric contraction. Isovolumetric contraction. Remember, all the blood, okay, all the blood from the left atrium, is shifted toward the left ventricle. Okay, and mitral valve is closing. mitral valve is closing. Now left ventricle is pulled up. It is has been filled with the blood. Okay. So when the mitral valve is closing and aortic valve is opening, the phase between these two valve changes is called isovolumetric contraction. The word iso mean is the same. Iso mean same. Volumetric mean volume, same volume and contraction. Left ventricular tries to contract the muscles, but volume is same. You can see in this picture, this is number one, this is a same volume. There is no change in this diagram. This is same volume, okay? This is same volume, this phase, okay? Now it is isovolumetric contraction, which is very important MCQs. Very important MCQ here is the period of highest oxygen consumption. This is important MCQs for all the steps like USMLE, FCPS, and MDMs and NLE. Which of the following phase has highest oxygen consumption? Isovolumetric contraction. Next, systolic ejection phase. What is systolic ejection phase? This is a period between aortic valve opening and closing. This is two. You can see this. There was isovolumetric when there is a left ventricle preparing for contraction. Okay, isovolumetric is a phase when the left ventricle is preparing for contraction, but there is no change in volume. Still, the left ventricle has not started the ejection in isovolumetric. But in systolic ejection, the left ventricle starts ejecting blood. And when it will happen, when there will be an opening of aortic valve. Now you can see that this curve is tilted because now it is toward the decreasing volume in the left ventricle because the blood is going toward aorta. So this curve is like this phase. Next, isovolumetric relaxation. It is the reverse of isovolumetric contraction. Now what will happen? Aortic valve is closed. Aortic valve is closed. Where? At this point. Okay, and there will be production of S2 sound. Now in this phase, you can see there is a same like no change in the volume, no change in the volume, no change in the volume. But this is the period when aortic valve has been closed, okay, and mitral valve is being open. Okay, still mitral valve is not open, but it is a slight period when aortic valve is closing and mitral valve is opening. In this phase, there will be a same volume, but it will be a relaxation phase, not contraction phase. So this is the isovolumetric relaxation. What will be the next phase? Next phase is rapid filling. Rapid filling will be start when diastole will occur. Diastole will occur. What will happen when diastole starts is mitral valve opens. Okay, its mitral valve opens and there is the rapid filling. And after that, there is reduced filling just before the closing of the mitral valve. And the cycle starts again with number one, that is isovolumetric contraction. Okay, so in this, very important point was that when what is the end diastolic pressure? What is end systolic pressure? So end diastolic pressure minus end systolic pressure is called stroke volume. This is very important points we are discussing now. Stroke volume is from this to this. Very important. From this to this. This is stroke volume. Okay. Now, next important question is that what are the place where S1 and S2 are produced? That is very important. In which phase of pressure volume loops and cardiac cycle S1 and S2 are produced? Okay. You already, all the people know that S1 is produced when there is mitral valve failure. Okay, just before the isovolumetric contraction. And S2 produced when aortic valve closes. Okay, just before the isovolumetric relaxations. So in important MCQs for MDMS and FCPS students that comes in exam, it is a previous past paper questions. S1 occurs at the isovolumetric contraction and S2 occur at isovolumetric relaxations. This is very important MCQs. Okay. Here they will give you S1 and they will give you at this is S. Going to the next session, what are Vigor's diagram? Okay, what is Vigor's diagram? This is complicated, but it is very easy if you understand. Okay, what is Vigor's diagram? This is Vigor's diagram. We combine all the phases of the cardiac cycle. Okay, we will discuss what will be the aortic changes. Number one, this is a curve I am highlighting. This is the aortic curve. Okay. Number two, what we will also discuss what are the changes in the left ventricular pressure. This is left ventricular pressure curve. Next, we will discuss jugular venous pulsation, JVP. Okay. And we will also discuss the left atrial pressure. Okay. This is the left atrial pressure. This green. ये हो गया 1, 2, 3, and the fourth point we will discuss what are the change in the heart sounds during this cardiac cycle. And number 5 we will discuss the what are the changes in ventricular volume. It was the pressure here, but we will also check what will be the changes in ventricular volume. Okay, this was the fifth. And what are the sixth thing we will discuss is the also right atrial pressure curve, which is called JVP. Okay, so we will discuss last seventh point, that is the ECG changes. So one by one we will discuss it. First of all, you should know that we will study in start from the P wave. Okay, all the people know that P wave is starting when there is a atrial systole. P wave is starting P wave when there is the atrial systole. Okay, what will happen in this change? When there is a atrial contraction, there will be A wave in JVP. So right atrial pressure, this is JVP. So there will be A wave. So I am pointing the green with all these phases of the atrial contraction. What will happen when there is a atrial contraction on the ventricular volume? Not a much change. Okay. What will be happening in atrial contraction or atrial systole? S4, if there is any pathology. So very important. S4 occur when there is a problem in atrial kick. This is atrial kick. Okay. So whenever any patient like old age, hypertensive, hypertrophic cardiomyopathy, these all are having the atrial kick producing S4 because there is very important point, that is high atrial pressure. Because due to the stiffening, the left atrium has to put more pressure to pump blood from left atrium to the left ventricle. So this produces a pathological S4. That S4 happens in which patients with a ventricular hypertrophy, and it is associated with left ventricular hypertrophy. Also old age patient, and also the hypertension patients and HOCM, hypertrophic cardiomyopathy. Is that clear? Now, the next phase, which is atrial contraction, what will be happening? There will be A wave in the left atrial pressure. Likely, the jugular venous pressure is the right atrial pressure. Okay, so same is the waves in the left atrial pressure, but it's a different name. When we talk about JVP is the right atrial pressure, jugular venous pulsation. Same will be the A wave in the left atrial pressure. What will happen in the left ventricular pressure and aortic pressure? You can see in the diagram, this is aortic pressure and this is the left ventricular pressure. There not so much change, not so much change. So we discussed that in atrial systole, the major change I will highlight. These are the most important change that occur in the, that is the A wave production in the JVP during the atrial systole, atrial contraction, that is associated with our important pathology, that is atrial fibrillation. Okay, that atrial fibrillation that is absent. This A wave is absent. Okay, so there will be absent of the A wave in atrial, which is due to atrial contraction. This is very one important pathology. Next pathology due to production of S4 we discuss in the old age, hypertension and HOC. These are the most important. Next we will discuss the changes I will highlight this color. What are the changes in isovolumetric contraction? We will discuss now the systole. Okay. Isovolumetric contraction. What will be happening? You know that when QRS is ventricular depolarization. We already know QRS is the ventricular depolarization. Okay. So ventricular depolarization produces QRS. So this phase is QRS. QRS. So this all the phase like this is having isovolumetric contraction. What will be happening in this stage? What will be happening? Number one, we will discuss an ECG change, that is the QRS. Next, what will be changed in the GVP? No change. What will be the volume of ventricles? In QRS, when ventricles are starting to contract, but I told you already in isovolumetric contraction, volume is same. Like iso means same, volume means volume. So no change. It will be same in ventricular volume. So what will be production of the sounds? I told you important MCQs of FCPS part 1. Many time it is repeated question. S1. Production of S1 in isovolumetric contraction. This is important point. What will be the next in the left atrial pressure? That will produce the important in the JVP, that is the C wave. C wave. This is, but when it is always produced when there is a closed tricuspid valve, mean in isovolumetric contraction. Okay, C wave is produced when there is a right ventricular contractions, closed tricuspid valve bulging into the atrium. That C wave in the jugular vein is occurring in this isovolumetric contraction. Next, what will be the change in this isovolumetric contraction? In the left ventricular pressure, this curve, and aortic pressure, this curve. You can see in this isovolumetric contraction, there is no change in aorta. Aorta is like this, no change in aorta. Aorta having no change in pressure, but there is increased pressure of left ventricle. Left ventricle, increased left ventricular pressure, P pressure. So I repeat here, what are the changes in isovolumetric contraction one by one? First, we will discuss this ECG. It will produce ventricular depolarization starts produce QRS. And what will be changed in this jugular venous pulsation? Number 2 points that produces C wave. Next, what will be happen in the left ventricular volume? No change. Next, what will be change in the heart sounds that producing of S1? What will be change? What will be the change in the left ventricular pressure? It will be increasing. Left ventricular pressure will be increasing. What will be the change in aortic pressure? No change. Okay, so we discussed the atrial systole, we discussed isovolumetric contractions. Next, we discuss the rapid ejection phase. Okay, I will highlight this rapid ejection phase with a green color. Okay. Now, we are discussing this rapid ejection phase. Rapid ejection phase has not any significant changes in the ECG, but important point is that, very important point, when there is a rapid ejection phase, there is X descent. This is X descent. This is X descent. This is a deflection downward. X descent is a downward deflection in the jugular venous pulsation. Why? Because when there is ejection of the blood toward the aorta, ejection of blood toward pulmonary trunk from the right ventricle, what will happen? The tricuspid valve, which was tense and going into the right atrium, will move into the right ventricle. So the pressure in the right ventricle will be decreased. So it will be a descent, which is called X descent. And X descent is due to downward displacement of closed tricuspid valve during rapid ventricular ejection phase. Okay, we will study pathologies later on. First, you should study the normal. Okay, what will happen in the rapid ejection phase? First, we discuss not a significant change in ECG. Then second, we discuss change X descent in jugular venous pulsation that occurs in the rapid ejection phase. Now, third, very important point. What will happen in ventricular volume in rapid ejection phase? Of course, it is ejection. Blood is going out of left ventricle. So what will happen? It will decrease. Left ventricular volume will be decreased in rapid ejection phase because left ventricle is ejecting blood toward the aorta. Now, next, fourth point, That is, what are change in the heart sounds? No change, not significant. What are the change in the left atrial pressure? Same X decent. What are the change in the left ventricular pressure? This is left ventricular pressure. What will be the change? It will be increasing more also. But the significant change in this rapid ejection is that aortic valve opens before us, just before rapid ejection. That is an important point here. Aortic valve opens just before this rapid ejection point, and also aortic pressure is rising. Also, left ventricular pressure is rising. Here I will discuss one most important concept and MCQs. Okay, the left ventricle put pressure and it's match the pressure of aortic diastolic pressure. Okay, so the left ventricle has to develop so much pressure that it can open aortic valve. So why the reason isovolumetric contraction is important? Because left ventricle prepare itself so that it increases pressure slowly increases. But at this point, when left ventricular pressure is equal to 80 millimeter of mercury, which is our diastolic blood pressure in our normal body. So when the left ventricle starts increasing the pressure in isovolumetric contraction, but a phase will come just before opening of aortic valve, the left ventricle will have a maximum pressure, that is 80 millimeter mercury. So that aortic valve will open, and now aortic valve will open, and this curve will like this. This curve will be, this is called, this is, and this is called coinciding point. When the left ventricle having so much pressure, it opens the aortic valve. That is a most likely 80 millimeter of mercury, which is a diastolic blood pressure of our body. Okay. So we discussed the atrial systole, we discuss isovolumetric contraction, we discuss rapid ejection. Now I will discuss the next point, which is reduced ejection fraction. Reduced ejection fraction. It is also ejection, but it is reduced. What will be the change in reduced? Number one change in ECG, it will make the T wave. It will make the T wave. What will be changes in the jugular venous pulsation? Jugular venous pulsation. What will be the changes? Not changes. Not a significant. It's not important here. But what will be the change? It will be more reduction of left ventricular volume. Okay. In this reduced ejection, there will be more decreased in the left ventricular volume. That is a one significant point. And second was T wave. Next important point in this will be the necrotic notch. Okay. After this reduced ejection, what will happen? Then aortic valve starts closing. Aortic valve starts closing, and then what will happen? This is a phase where aortic valve closes. That is called necrotic notch. Okay, so this was a reduced ejection. Now we discussed all the phases of systole. What we discussed? We discuss atrial systole, we discuss isovolumetric contraction, we discuss rapid ejection, we discuss reduced ejection. Now we will discuss these phases. What are the diastolic phases? Okay. Now I will start with this blue color. What is isovolumetric relaxation? Iso means same, volumetric means volume. It is same volume. So one of the very important, you should know that volume is the same. Volumetric contraction or relaxation, it is relaxation. So you must know that when there is a relaxation, there will always be pressure will be decreasing in the left ventricle because it is a relaxation. So you must know that left ventricle will be decreasing its pressure. That is, of course, very important. Now you should know that when there is isovolumetric relaxation, there will be a filling phase. Start in the atrium. There will be a filling phase when there will be start in the filling of the atrium. right atrial filling will be started. That causes a willing phase, filling phase, willing phase, filling phase, willing phase, filling phase. We say willing, filling, right atrial filling, willing. Remember, this is causing the V wave. This is causing the V wave. Okay. So next, what will be the change? Isovolumetric relaxation, very important MCQs. It is producing S2 in the heart sounds. S2 in the heart sounds. Okay. Now, next phase. Next phase is the rapid ventricular filling. What will be occurring in rapid ventricular filling? First, start with ECG, not a significant change. Okay. Now, what will be occurring in this? Right atrial pressure or JVP, it will be a Y descent. Rapid ventricular, it is a Y descent. We will study the pathologies in a few minutes. What are the pathologies of JVP and what are the associated conditions? We will study separately. But understand the basic things. A Y descent will occur in the rapid ventricular filling. Okay. So in rapid ventricular filling, if there is any pathology, the S3 develops in rapid ventricular filling. Remember S3. What is S3? S3 is early diastole. It is a sounds in early diastole during rapid ventricular filling phase. It is a best heard with left lateral decubitus position. It is important MCQs for all the exams. What are position that the S3 and S4 are heard loudly? What are position that S3 and S4 both are heard loudly? This is left lateral decubitus position. Left lateral decubitus position. Remember this. Left lateral decubitus position, that is very important MCQs. Okay, so S3 produces in the rapid ventricular filling phase. It is associated with increased filling pressure, like any heart that has dilation, like any condition that causes left ventricular dilation that produce S3. Remember my word, left ventricular dilation causes S3. What are the conditions that causes this dilation? Mitral regurgitation, aortic regurgitation, heart failure, thyrotoxicosis. It is more common in dilated ventricle. And S3 is normal in young adults. But what are the important? That is the which age? Less than 30. S3 is normal less than 30. Normal in young athletes. Normal in pregnancy. Okay. So this is very important. Next very important point that is in this curve, which is the very important. What is the valve? You know that it is left ventricular pressure is more decreasing. Okay. So we discuss in rapid ventricular filling phase. In JVP, there was a Y descent. In the heart sounds, if there is any abnormality or young athletes or pregnancy or young adults, if there is a dilation of the left ventricle, there will be S3. And there will be more left ventricular decrease in left ventricular pressure. And very important points here, very, very important points. What will be change in ventricular volume? Because it is a filling phase, it will be going up. It will start to increase in this rapid ventricular filling phase. So it starts to increase. That is very important. Okay. So we discuss rapid ventricular filling. Now we will discuss reduced ventricular filling. Reduced ventricular filling by this color. Reduce ventricular filling. Okay. Not a significant change in this. Okay. Not a significant change in this section. Oh, sorry. Mistakenly, I have just let me share it again. Okay. Okay. So we were discussing this point, which is rapid ventricular filling. Rapid ventricular filling in ECG, there is no changes. In JVP, what are the changes? No changes. In the ventricular volume, number third, ventricular volume, there is slightly increase, but there is a static What will be changes in the left, in the heart sounds? There is no change. What will be the change in the, what will be the change in left ventricular pressure? It's static. Okay, it's static. What will be change in aortic pressure? No change. So there is a not significant changes in reduced ventricular filling. Is that clear? So now we discuss what are the different changes in Vigor diagram. This is, we discuss all this one by one in collaboration with the 7 different phases. Like one was this aortic pressure, second was left ventricular pressure, third we discussed the left atrial pressure, fourth we discussed the association with heart sounds, fifth we discussed the ventricular volume, sixth we discussed the JVP, and seventh we discussed the ECG changes. This is called Vigor diagram. Vigor's diagram. Okay. So now we will discuss some pathologies and a quick revision of our sounds and phases. What are the different sounds? S1, S2. We will discuss the MCQs. S1 is produced when there is a mitral and tricuspid valve is closed. S2 is produced when aortic and pulmonary valve is closed. And the FCPS and MDMS part 1 question. Okay, some our students are saying there is a no voice. I think it's clear. Is there any other student who has issue with the voice? Okay, it's clear now. Thank you, thank you. Thank you so much. Okay, we are continuing our lecture. S1 is mitral and tricuspid valve player. S2 is aortic pulmonary valve player. Okay, we discussed the 2 very important MCQs here. S1 is in the isovolumetric contraction, and S2 occurs in the isovolumetric relaxation. That is the very important MCQs. Next is S3. S3 is produced in the dilated. S3 is dilated left ventricle. Remember this. And that dilation is mitral regurgitation, aortic regurgitation, heart failure, and less than 30-year age of the young adults, athletes, and pregnancy. Okay. S4 is due to atrial kick, that is associated with the hypertension. Okay, that is associated with old age, associated with hypertrophic cardiomyopathy. Okay. So next we will discuss the pathologies that is associated with jugular venous pulsations. Jugular venous pulsations. Okay, JVP. First is A wave. A wave is associated, A is atrial contraction. Atrial contraction. Okay. It is absent in atrial fibrillation. Remember, this is very, very important MCQs, very, very important MCQs for MD, MS, FCPS, NLE, and USMLE. Most repeated question, it is a previous past paper question of FCPS, MD, MS, and NLE. And the next is C wave. C wave is due to right ventricular contraction, because when there is a closed tricuspid valve which is bulged into the right atrium. We discuss this C wave here. Okay. And during the isovolumetric contraction. Next is X descent. X descent is downward displacement when there is the ejection phase of, when there is a right ventricle is trying to eject the blood, then what will happen? The tricuspid valve will come back in its position, and there will be a decreased flow, decreased volume of the blood, decreased pressure in the right ventricle. That will causes a downward deflection. So, okay. So this is very important pathology associated in X descent. X descent is absent in tricuspid regurgitation and right heart failure. Why? Because the pressure gradient reduced. Okay, X descent pathology is, it is reduced or absent in tricuspid regurgitation and right heart failure. Okay, why? Because pressure gradients reduced, because there will be no ejection. When there is no ejection, the same tricuspid valve will not go into normal position. It will be more stretched toward the right atrium. So when it will be more toward the right atrium, it will put more pressure on the right atrium. When it put more pressure on the right atrium, it will not be the descent. It will be like this. It will be no descent. So in the tricuspid regurgitation and the right heart failure, the X descent is absent or reduced. Next very important point, that is willing phase, filling phase, willing phase, filling phase, filling and willing. Remember, V is always willing and filling, willing and filling, willing and filling. Okay, filling against closed tricuspid valve. That is very important. Okay, that is not important MCQs regarding this, but the next very important is the Y descent. It will occur when the right atrium is emptying the blood into the right ventricle. Okay, so Y descent is prominent and sometimes it can be the absent. So it is absent and prominent. Absent and prominent. Absents occur in which diseases? Cardiac tamponade. Absent in cardiac tamponade. Okay, and prominent in which disease? It is prominent in constrictive pericarditis. Constrictive pericarditis. Okay, this is very important MCQs. Remember this. Okay. Okay, so we discussed this Vigor's diagram that are okay. So we discuss the pressure volume loops and pressure volume loops. There are different changes. So we will study what are the changes in pressure volume loop if we increase the afterload, if we increase the preload, if we increase contractility. Is that clear? So first of all, we will discuss when we increase afterload, what change will happen. We discussed that this phase is called end diastolic volume. This is end systolic volume. Is that clear? Now, this phase, you can see in this picture, this is isovolumetric contraction. And in this diagram, when I increase after load, what will happen? Left ventricular pressure will be high. First change when we increase after load, increase left ventricular pressure. Because left ventricular has to put more pressure to compensate to make the ejection. He has to make more work. He has to produce more work. So what will happen? The aortic pressure is increased. It means after load is increased. So what will happen? Left ventricular pressure will also increase. Next, what will be the second change? First is left ventricular pressure increase. What will be the second change? Decreased stroke volume. Decreased stroke volume happen. Why? You can see in this picture that this new curve is here. This was a normal and systolic volume, but the new volume at this level. So this is decreased space between this and this. So that means it's decreasing the stroke volume. So next change in increasing the afterload, increasing peripheral vascular resistance, this pressure volume loops and cardiac cycle curve, it will be decreasing the stroke volume. Next, what will be decreasing? Ejection fraction. Okay, but mild, slightly decrease in the ejection fraction. Okay, next, what are the changes when we increase the preload? So when we increase the preload, it means there is the more volume in the left ventricle. So more volume in the left ventricle will causes more end diastolic volume. So you can see this was the normal, but new curve is here, which is going more toward this forward, that is end diastolic volume. End diastolic volume. Is that clear? Okay. So the next picture is systolic dysfunction. What happens in systolic dysfunction? In systolic dysfunction, there is decreased contractility. In decreased contractility. And what will happen then? Due to decreased contractility, there will be more of the blood remaining in the left ventricle. Why? Because there is not, left ventricle is not pumping all of the blood. So it's mean end systolic volume will be increased. Because after the systole, some of the blood will be remain in the left ventricle. It means there will be more end systolic volume as compared to the normal condition. So you can see this is end systolic volume. It is greater or much as compared to normal. But end diastolic volume is the same because there is a no preload increase. It is same. So what will happen? The difference between them is contracted. So it's mean stroke volume will be decreased. So in heart failure patients, there is decreased contractility, increase end systolic volume, and decreased stroke volume. And also mild decrease in ejection fraction. Okay, so this was the concepts associated with these the curve, we discuss pressure, volume curve, and now we will continue a very, very important topic. So next, what are the Canon A waves? Actually, sometime it is also asked, what are the Canon A waves? Okay, what are the Canon A waves? Canon A waves is actually A waves. This is due to complete atrioventricular block and associated with ventricular tachycardia. It is not asked in CPS MDMS student, but sometime it is asked in USMLE Step 1. Canon A waves, these are associated with the ventricular tachycardia. Just this, remember this. These are the long A waves, like this. These are the Canon A waves. Okay, so we should take some break, and after that we will join again. Okay, it just take a 10 minutes break. Okay, like 5 to 7 or 10 minutes, not more than that. Is that clear? Of our next topic. So now we will study what are the pressure volume loops and the valvular disease. First of all, we will study the aortic stenosis. What are the changes in aortic stenosis? First of all, you must know that there is a stenosis in aorta. When there is stenosis in aorta, there will be a more pressure of aorta. More left ventricular has to make some compensation. What compensation left ventricular will make? This will makes the hypertrophy. Okay, left ventricular will make some compensation, that is hypertrophy, because there is a more stenosis in aorta. So more work has to be done from the left ventricle. So when more work has to be done from the left ventricle, then what will happen? Then what will happen? It means there will be more left ventricular pressure. Okay, so more left ventricular pressure. More left ventricular pressure as compared to aortic pressure. It is characteristic finding in the aortic stenosis. You can see in this diagram, which is Vigor diagram we studied previously. In Vigor diagram, this is red is aortic pressure and this blue is called left ventricular pressure. And you can see that there is a gap between them. Left ventricular pressure is going up, like in mark, I can mark in blue. This is left ventricle. This is up as compared to the red. This is aortic pressure. So this gap is in the aortic stenosis. Remember the one very important point here. Okay, you can see in the picture in the left side. Okay, in the picture on the left side. Okay, in this diagram, you can see this is aorta. This blue diagram, it is aorta, and the green diagram, which is left ventricle. So you can see there is a pressure difference between them. Okay, there is a pressure difference. Okay, what will be happening the next? Pressure is increased. What is the next important point in aortic stenosis? Increase and systolic volume. Why? See this picture. Because there is a stenosis in aorta, left ventricle will have to put more pressure. It means it needs more work, but it cannot put all of the blood out of left ventricle. Some of the blood will be left after systolic. It means and systolic volume will increase, like in this. Okay, is that clear? Okay, I know, it's very difficult. It's very difficult, but you have to understand. It is. I am making it more easy. Okay. आपने उसे किसी ने कोई suggestion देनी है तो you can tell me. Okay, I can make it more clear. I can make it more easy for you. Okay, so we are discussing this pressure volume loops, and association with valvular diseases. We are discussing first aortic stenosis. Okay, aortic stenosis. What will the first change? First change in this diagram, you can see that there is increased left ventricular pressure and there is increased hypertrophy of left ventricle because there is the more aortic pressure. So left ventricle has to put more work to compensate this aortic stenosis. So it will be more pressure in left ventricle as compared to aorta. And what will be the next change? Next change is increase and systolic volume. In this diagram, you can see that in the red section, this is in aortic stenosis. What you can see that this pressure is going upward. This phase, this is normal. It is going on the upper level. This means pressure is going upward. This is increased left ventricular pressure. And this is end systolic volume. It is going toward this side. It means more end systolic volume, but there will be no change in end diastolic volume. No change in end diastolic volume. When there is a contraction, mean there is a less space between these two, it decreases stroke volume. That is important for the aortic stenosis. Next, what is in change in mitral regurgitation? In mitral regurgitation, what will happen? There will be decrease and systolic volume. Why? Because there will be more more of the what will happen? Stroke volume in early mitral regurgitation. Why? Because more of the blood is coming from regurgitant murmur. From the mitral regurgitation, the left ventricle are giving the more and more blood on the left ventricle. Left atrium will giving the more blood to the left ventricle. So the difference between them is very large. So first of all, you should know that in acute mitral regurgitation, the more is the blood coming from the left atrium, it will increase the stroke volume. Okay, it will increase end diastolic volume, and it will decrease end systolic volume. And systolic volume is decreased because decrease resistance and increase regurgitation into the left atrium. This is a very important point to remember. Many of the students say why it is decrease and systolic volume. Actually, it is the blood that will went into the left atrium. That's why it's decrease and systolic volume. Okay, one blood that is coming toward the aorta. This is the left atrium, and this is left ventricle. Okay, and the blood is going from this left ventricle into this aorta, but some of the blood goes into the left atrium. So at the end of the systole, end systolic volume become less because a few quantity of the blood will go into the left atrium. That's why end systolic volume is less. And there will be a tall V wave. Okay, this is very important point. And the next is aortic regurgitation. What will happen in aortic regurgitation? Aortic regurgitation, it will be no true isovolumetric phase. Okay, because there is regurgitation from aorta in back into the left ventricle. So what will happen when the left ventricle is having more blood because aorta is regurgitant? Then in the next cycle, in the next phase, there will be more blood. There will be more blood in the next phase. Okay, and there will be more blood. There will be more end diastolic volume. There will be more systolic volume. And very important point is that the very important in aortic regurgitation, what will happen? The pulse pressure is decreased. Okay, so pulse pressure is decreasing, stroke volume increasing, and diastolic volume is increasing, but pulse pressure is decreasing. Okay, and the next is mitral stenosis. Very important exam point of view for USMLE students. This is very important. Okay, mitral stenosis. What will be happening in mitral stenosis? First of all, left atrial changes. Left atrial pressure is increased. Why? Because left atrium is putting more pressure. So this curve, which is left atrial pressure curve, will be up. It will be high as to the base. The base level is like this, but it is up. Increase left atrial pressure and decrease end diastolic volume. You can see in this diagram, this is the decrease toward, this is normal, but this is decrease and diastolic volume because of impaired ventricular filling. Decrease and systolic volume, you can see that this is coming backward. This is decrease and systolic volume, and also decrease stroke volume because both are decreasing, and diastolic and systolic. The difference between them is also decreasing. Okay, so this is seen in the mitral stenosis. Okay, you can see in the diagram that it is the base level at this position, but is going upward. This is seen in mitral stenosis. This is seen in mitral stenosis. Is that clear? Okay. Okay. Now,